Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is Irido corneal endothelial syndrome. Irido corneal endothelial syndrome basically consists of three types: essential iris atrophy, Chandler syndrome, and Cogan-Rees. It is basically an abnormal corneal endothelial cell proliferation. The cells proliferate into the angle and then go into the iris. It is usually sporadic, and females between the 30 to 50 years of age bracket are affected. Its pathogenesis basically has been attributed to 60% presence of herpes simplex virus 2 in the anterior chamber aqueous humor and it is confirmed by the PCR. These cells, endothelial cells, develop desmosomes, intracytoplasmic filaments, and villi, just like the epithelial cells, and this has been attributed due to the repair process due to repeated attacks of viral infection. It is unilateral disease, and it is considered as one eye is affected by virus in postnatal age, the other eye is protected by immune system which has started working. This disease is usually triggered by uveitis, and glaucoma has been seen in 46 to 82% of patients. It is clinically differentiated from posterior polymorphous dystrophy because that is bilateral. And Axenfeld Rieger's, on the other hand, is also bilateral, but that is congenital and stationary, and it shows minimal worsening. Gonioscopy is very difficult in these patients, so we have to take the help of UBM to see the anterior chamber angles. As our main case today is Chandler syndrome. So Chandler syndrome is basically marked by corneal edema with decimus folds, while peripheral anterior synechiae are less evident. Late iris abnormalities can develop, and glaucoma develops due to the peripheral anterior synechiae and angle closure. If we talk about the medical treatment, we can give beta blockers, alpha agonists, not prostaglandin analogs, which are relatively contraindicated. But this medical treatment is not successful in managing this type of disease. And trabeculectomy has been done and tried with mitomycin. So it shows 60% success rate after 1 year and 40% after 2 years. As compared to TRAB, if we talk about glaucoma drainage implants, 70% after 1 year success rate and 53% after 5 years. So two things we are managing in these patients. Usually we are worried about the cornea, we are worried about the pressure. The other thing is corneal management. Corneal edema, patient cannot see. So penetrating keratoplasty can be done to have good visualization, but its failure rate and rejection rates are very high. So considering this, people have attempted DZAC, DLAC, and DMAC. It shows promising results with further results and analysis being awaited. So this is the image of our patient, 35 years old lady, came to us, unilateral eye, right eye involved. You can see the corneal opacification over there, but behind, if you can see, the iris looks okay, not bad. And in this corneal slit image, you can see the corneal edema even also, and it shows better the anterior chamber. Depth is okay, and if you see iris, it also looks normal. UBM, we did UBM in the right eye. You can see the anterior chamber angle is still open. Yani, disease has not proliferated up till the angles. Corneal edema, you can see it is crossing 664, while in the left eye you see angle is wide open And if you see the under it, the photograph, it's normal eye, no problem with it. So we received this patient, uh, basically already seen by uveitis, no active inflammation was there, and even glaucoma team also examined this patient, and they mentioned it very rightly that the pressure was not high, and they also pointed towards the eye syndrome. So it was a case being managed by three teams: cornea, glaucoma, and uveitis. So in cornea team, its anterior chamber AC aqueous humor tap was done and sent for herpes virus and cytomegalovirus virus PCR. The results came after 1 week, and these were negative. As I've already talked about, that even 60% of patients only show positivity in aqueous tap. The other thing was that this patient was put on Valgan cyclovir, 900 milligram, 12 hourly, and keeping an eye on the renal panel. Topical hypertonic saline was also advised to maintain the clarity as much as it was possible. But the vision in the right eye is now you can see the edema. It is almost counting finger 3 feet, while the left eye is good vision 20, 30, 20, 20 vision in the other eye, which is the normal eye. Pressure is still normal, 18, 18 both eyes, and the angle is still not involved. So this is the case I wanted to discuss with you, and this patient is we are planning to go for the DZAC, but usually these patients have to be taken into confidence because it is a very challenging disease to handle. Counseling has to be done because the virus which attacked earlier and started this disease can again cause uh, attack the newly implanted endothelial cells. And if we see the literature, still research is going on over there, which one is the best treatment modality. So this was the case I wanted to discuss with you, the Chandler, which is not very common disease. And I want to thank Professor Abdul Al Fawaz, Chairman, Professor, Corneal Refractive Surgery, King Saud University Medical City, for giving me these slides and images. And the literature review was done by the article Diagnosis and Management of Eye Syndrome by M. Sacheti, and it is a free PMC article. Thank you for your attention.